Welcome to Philosophy.
The Business of Benefits is your no BS, no sales guide to real solutions.
No gimmicks, just the truth about how to take control, transform your benefits, and care for your most valuable asset, your people.
If you're tired of the same old sales pitch and you're ready to rethink your benefits, this podcast is for you. The truth is out there. Are you ready to hear it? Hi, everyone. Welcome to another episode of The Business of Benefits. I am your host, Chelsea Ryckis, and today I am joined by industry colleague, and I actually consider you a friend, Zeev. Hope you don't mind that. Dr. Zeev Neuwirth, who is a very prominent figure in healthcare. The reason I wanted Dr. Neuwirth on our podcast today is because he's actually on somewhat the opposite side of the industry that I am, but I feel like our two worlds, while they're often siloed, there's so much overlap that impacts employers, and I think we can have a really good conversation about that. So what I mean by that, listeners, is obviously ethos benefits, employers, we're always talking about how are we paying for healthcare, right? Healthcare financing. What Zeev is focused on is healthcare delivery, right? How are the employees that we're serving actually experiencing healthcare on a day-to-day basis? So he's written two books. One is called Reframing Healthcare, the other Beyond the Walls. And he's got a very interesting perspective on healthcare delivery and ultimately the financing side as well. So welcome. How are you?
Chelsea, I consider you and Donovan friends. I also just want to say I listened to your podcast. I've learned so much from you. I've seen you work, and I just wish we had more professionals like you in the business. We need it. We really desperately need it.
I appreciate that, Zeev. Thank you. So let's catch our listeners up on kind of what you've been doing the last decade or two, however long you want to share, and just maybe a little bit about your books, and then we'll kind of get into some of the healthcare delivery questions that I had lined up for you.
I started my career as a practicing general medical internist in an academic medical center. So I saw lots of patients both in the hospital and in the outpatient setting. And I did a lot of teaching to generations of internal medicine residents in training. Early on, I was really, this is decades ago, three and a half decades ago, I was really frustrated and upset by how the system treats individuals, and this was back in the 90s, and it was really treating people like numbers. It had really become a business, and this was in sort of the after the Clinton era, after there was this hope that Hillary Clinton was going to, help clean up healthcare, and that went away in like a millisecond, and we were left with really it was pretty destitute. And so I started to study literally how the patient experience, the family experience, and also the provider experience, and it was pretty awful. And the sad fact is it's gotten worse over the past few decades. And so I made it my point, here I am in the, kind of clinic exam room in the hospital doing medical work, but, and going to administrators and saying, listen, we have to change this, and, kind of getting patted on the head. And that's the last thing I realized anyone should do, is pat me on the head, because that made me really angry and frustrated. And so I said, well, I'm going to understand the system better and better. And so I spent the last 30 years really truthfully just trying to understand the system from the inside and from various perspectives. I moved from being a practicing clinician to, which I was for probably between 15 and 20 years, to being a manager, to being a process improvement expert, a quality improvement expert, population health, medical director. I've done clinical operations. I've been at some of the largest and most prestigious institutions in the country, managing literally hundreds, if not thousands, of providers at the same time in hundreds of sites. And so I've had the opportunity to be on the innovation side, partnering with retail chains, doing home-based care, remote patient monitoring, virtual care, getting into segmented care like senior care, which no one had really been thinking about as sort of a separate activity. And then most recently, and I think the way we met in part was I spent the last year, I left after 3 decades, I left the big institutions, the big healthcare systems that I'd been in for quite some time. And I joined an early stage startup that was doing Medicaid managed care. And although I have spent some time in employee care, this past year has really opened my eyes a lot more as I've really studied capitation, talked to employers, worked with brokers like yourself and advisors like yourself. And although no one's quite like you and Donovan, so um, but um, but I've really sort of seen the system, and I have to say, I don't think that most people appreciate the importance and the magnitude of employer-based healthcare in the larger industry. I would venture if you did like a spot like test or check or kind of quiz, I would say most administrators, most leaders, and for sure most clinicians would fail it. I mean, if you ask them how many Americans get their healthcare insurance through employer-based care, independence, I doubt people would be able to tell you. It's close to 180 million people. 54% of the population. What percentage of the dollars go through the employer base? I don't think people would be able to tell you how much money is wasted. Did you realize that health insurance is actually a hidden tax on your wages and has been causing wage stagnation for decades? Do you realize how much money you would have in the bank had healthcare been much more efficient, if there hadn't been this I don't even know what to call it. We talk about a medical industrial complex. That's a term that's been used. Yeah, if I can share more about that. It was first used by the editor of the New England Journal of Medicine. Actually, it came from Eisenhower. In his last speech as president, he talked about the industrial complex, and Dr. Relnick, who was the editor in chief of the New England Journal at the time in the 80s, copied that and said, I'm really concerned we've turned into a medical industrial complex where it's this relationship of the industry and of government that is really destroying healthcare, and it's less about people and it's much more about the industry and profits. I don't think Dr. Relnick had any understanding of what would be happening in the employer-based healthcare, where you would have all these middlemen. I mean, the insurance companies, the PBMs, the TPAs, the benefits advisors, all taking a piece of the action. And I don't even know how else to put it, right?
No,
It's
perfect.
more interesting than any sort of mob movie I've ever seen. I mean, it makes the mob look like a joke. I mean, if you look at, in terms of the dollars that we're talking about, how they're siphoned off. So they're not going to the employee, they're not going to the employer, they're not going to the patient. And truth be told, they're not even going to the providers. I was talking to someone recently, they said about 20 cents on the dollars in healthcare goes to, doctors, nurses, other clinicians. 20 cents, 1/5. That means 80%. I mean, I studied Toyota Lean production system, and we talked about waste, and, the value added is, the clinical folks providing their expertise to you as a patient. And yet you give the dollar and you might as well, you cut out 4/5 of that dollar because it's going to all this interim administrative bureaucratic. And, if it were just pure inefficiency, and there's obviously a lot of pure inefficiency, a tremendous amount, but if it was just pure inefficiency, you would say, okay, listen, guys, we got to get more efficient. The problem is it's not. And you know better than I do that it is these misaligned incentives. And it's so perverse, where people are making money and companies are making money at the expense, not helping the individual employee or patient, but actually harming them. And that's really upsetting. When I realized what was happening, that shill game, and it just, it's sad, it's upsetting, it's frightening. And now, from my perspective, as obviously someone who's been interested in this for 30 or 40 years and has made it my career. As you know, I've got a podcast. I've got over 200 interviews posted. I've done probably 500 interviews over the past few years. I've written these 2 books. I've written articles, and I'm in the game. I continue to I refuse to sit on the sidelines and, and be a jaded observer. It's my purpose and my passion to actually, until I can no longer do this work, to really try to make the system more, for lack of a better word, it's really about it's about humanizing healthcare, and there's no one, any one of your listeners here, anyone else who might listen, and they might, they may not be experts in this area, but it will affect them. It will impact them terribly. And the problem is, and some people think, oh, I have enough money to get around this. There are very, very, very few people. We're talking about 1% of the top 1%. You think you have the money, you think you have the connections. I mean, my wife and I are both doctors, and we're nearly helpless in the system. I mean, she's an expert in so many facets. I have expertise. It's not like we're poor, and there's no amount of money that I could imagine that could actually solve our problems or expertise. And I feel my experience recently, and we could talk about it as a caregiver for my wife, that experience, more than anything else, I sit there and wonder to myself, I mean, we are so blessed and in many ways so privileged, and we're in a position where we have friends and colleagues who are literally running healthcare organizations, who are experts like yourself, where I could literally pick up the phone and get this, tremendous advice, be connected all over the country. And I think to myself, and yet with that, we still struggle beyond belief. But I think to myself, what about the 99 point, 9% of the population that doesn't have the money, that doesn't have the wherewithal, that doesn't have the contacts and connections? I mean, it really, I think at this point, I would say that my experience, especially over the past year or so, I would say that the majority of Americans do not have access to primary care, to preventive, proactive primary care. And that's the knell. That's the canary in the coal mine. This is when people start to really, and not metaphorically, but really, people are dying. And it's, it's not the other. It's not those other people. It's us, all of us.
Caregiving, primary care specifically. But before we get into those topics, I had a question. So you were saying, what I took from part of what you said is you've worked with some of the most brilliant, established people, organizations, institutions within healthcare over the last 3 or 4 decades. Yet there seems to be this kind of complete misunderstanding, and I want to say the word ignorance, but it's not ignorance in the sense that it's like, you're doing something wrong. It's like true ignorance, where it's just like, well, there's employer sponsored healthcare and group commercial insurance. And that's just something that sucks. And we can't really do anything about it. And healthcare inflation and medical trend and blah, blah, blah. Obviously, you and I now know, right, that that's a lie, perpetuated by people who are profiting immensely from them believing it and the status quo just continuing as is. But these people are so smart. And I just have said, I really want to dig a little bit deeper into why is there such a resistance to believe that there's a better way to finance healthcare or to offer healthcare delivery and primary care? Where do you feel like that resistance stems from? Because these people are smart, right?
I mean, it's really, so first of all, the people in the system, I mean, despite the fact that, hospitals and healthcare systems are struggling, or at least it's more challenging financially than it was in the past. And and the same is true of insurance companies, large health plans. I mean, you hear what's happening with Centene and United Healthcare, et cetera. I mean, it's all relative. If you look at the amount of money that they're making and their margins, I'd like to struggle like that too, personally. So, but there's tremendous revenue being made, and I just think it's I don't, It's hard to point fingers because there's so many different stakeholders involved, and it's I hate to use this word, but it's an ecosystem, and there's a lot of interdependency. And and the add on top of that, change is very scary. I mean, even if you talk to employers and you say, and I'm sure you know this 1,000 times better than I do, you talk to employers and say, look, here's a better way. I can provide you with lower cost insurance and lower cost health care, and it's actually more access and better quality for your employees. They're going to save money, they're going to be healthier, they're going to feel better about you, and yet they're still going to hug to the old system because it's kind of the devil is better than what you don't know. So I just think it's a very healthcare is one of the I think it's the biggest, hairiest problems we have in the United States right now. And again, it's just so embedded. And so I think the more interesting question is, okay, first of all, for me, and as I've worked as an executive over the years, and I'm known for this question, I always ask the people I work with, what's the problem we're trying to solve, right? It's really important. And in this case, it's not just what's the problem, because it's not a linear
No.
problem, right? It's a super, super complex problem. And so you're faced with a problem like this, you really have to spend time. It's like that Einstein quote where he said, if I had a problem, to save the world, and I had an hour, I would spend 59 minutes studying the problem and 1 minute, putting the solution together. And I don't think we've done enough of the 59 minutes. And in fact, I like that. I might actually quote myself.
You should quote yourself.
No, I think we have a 59-minute problem.
Yes.
I think that we haven't looked at it, to answer your question, in that, well, what is the problem? I'm obviously, I'm passionate about primary care. I have been for 40 years, and it's my profession. That's what I was trained as a primary care doctor. I practiced for years and years as a primary care doctor. I taught it. I've worked on it as an executive and whatnot, an innovator. And I really think the 59-minute problem is the problem we have in primary care. It's getting very, very honest with yourself in terms of, what are we actually trying to do? What is primary care? What are we trying to achieve? What is health? What are we trying to achieve? And I think in this case, you start to realize that health also includes financial health. And I think that's where spending time dissecting the problem and asking, and the question is, I think we're at a point in time where the employers are feeling so much pain, people are feeling so much pain, employees are feeling so much pain, their family. And again, when I can't get primary care. I mean, I'm going to tell you, I live in a wonderful city with amazingly wonderful, world-class healthcare centers, and it's really it's a medical town, if you will. In part, it's becoming known for that, world class, and so many. I mean, people fly in from all over the world now to come here, and I, as a physician, am scratching my head and wondering, how do I find a primary care doctor?
It's
It
wild.
it took my wife weeks to get a primary care appointment. She was ill, and so it's such a huge
True
problem.
crisis. What do you, just the access problem, right? Like, and in primary care, if designed appropriately, and let's talk to our specific audience, which is employer plans, right? If you use your plan design to have primary care, like let's say direct primary care, for example, right? Which, for employers that are listening, what that would be is the employer is sponsoring literally a local practice. And you can do this multi-state. We have clients with thousands of employees and dozens of locations. And we can do this where each employee has direct access to a physician via text, in person appointments, whatever they need, virtual, but it's same day. So there's none of this 3 to 5 week wait time. And that doctor, because they're the direct primary care doctor, they know the playbook for the health plan. So we train them. They can see, okay, we have, if they need a specialist, this is the cheapest, best, highest quality place for them to go. If they need imaging, we have direct contracts with these imaging centers. Employees can get imaging for free. And instead of, the traditional experience, which is waiting 3 to 5 weeks, and then you're basically going to get funneled through a system that everybody wants you to go to because they get kickbacks or whatever the situation is, they're owned by this other physician group, et cetera. So that is, I think there's so much that can be done in terms of crafting a great healthcare delivery experience that genuinely starts with primary care. What do you think is maybe like a misconception about primary care, or something that like employers could learn from you, who's been doing it for decades?
Wow. Oh, first of all, I love the picture you painted. I think that's the way healthcare has to be thought of and constructed as, and again, as sort of an ecosystem, right? You set it up in that way so it's comprehensive and there's pathways. It's not a hit or miss. It's not, left up to the individual to figure out where am I going to scramble, et cetera. So I think there's wisdom in that description you just, pointed out. And I'm sure there's variations we could create on it, but that general concept, the misconception or the misdirection of primary care I'll tell you the truth. From an industry perspective, primary care, and some people may have heard this term, some people may not. Primary care is considered a feeder. It's a channel. So that's how in the business, primary care, hospitals want primary care, healthcare systems want primary care, payers want primary care. Why? Because patients go to their primary care doctor and then they get funneled to specialists and radiologists and to surgery and to hospital beds. That's from a business perspective. I mean, this is common. This is well known. I don't think I'm talking out of school. I mean, every healthcare system, I could go to any C-suite in any hospital system in this country and say primary care feeder, and people would clearly understand what I'm talking about. So it's no secret. And that's the problem when, primary care is a feeder, then, and that's the problem you're trying to solve, is you're trying to feed the beast. Then, primary care visits become, 5 minutes, 10 minutes, and you essentially, and you pay your doctors by, volume and churn and how much they're, charging during those visits, how much they can squeeze in and charge the so-called RVU, relative value units. This is the way this is reality. This is how it works. And what's happened because of that misunderstanding, misdirection, misalignment, if you will, of what primary care is, we've denuded primary care. And this, to me, as a primary care physician, someone who made a decision, I wasn't going to be a surgeon or a specialist. I really wanted to, be a primary care physician. The allure of that, the purpose of that, was to spend time with people, to get to know them, to provide, now we call it, kind of a, sexy term, whole person health, whole health. That was always what primary care was. I mean,
Nothing's changed.
talk to you about your family, your diet. This is now we have the social determinants of health. It's like all this stuff we knew in primary care. And believe me, we wrote about it. It was in the literature. This is nothing new. We understood this. This is what saves lives. This is what prevents illness, community. But when you denude primary care, and essentially that's what we've done, we've perverted it and we've destroyed it. This is why no one wants to go. Very few people want to go into primary care. Very few people stay in it. I was just talking to an executive, and this would be true, I think, across the country in every institution, who said that he doesn't understand why his primary care doctors tell him that it's impossible for them to be full-time doctors. They can't handle more than, 2 or 3 half-day sessions a week. There's something, well, I understand. There's there's lots of reasons for it. One of which is you're spending most of your time just dealing with the bureaucracy of
Administration.
prior authorizations and stuff. This is not what you spent umpteen years,
And a lot of money.
a lot of money, umpteen years. And these are brilliant people we're talking about, right? I mean, if they wanted to be, there's nothing wrong with administrators or bureaucrats, but if they wanted to do that, that's what they would have gone into. And yet that's what they're finding that their lives are like, and they're not able to spend time with patients. And so I think that I think we really, and I think some of these movements, like the one you were talking about, direct to consumer, direct to employer, where you take all that stuff off of the primary care physician's plate, and you say to them, listen, you're going to spend most of your time actually taking care of patients and not filling out prior auths or talking to insurance people so your patients can get the care that they need. You know, filling out claims and billing. And I mean, it's really remarkable when I look at my colleagues who, again, I can't tell you how smart, how well trained they are, how well meaning they are, and what they're doing with their time. And this has been documented, right?
Yeah.
That for every hour you spend seeing patients, it's at least probably double that doing paperwork, which is, and there's no reason for it. There's no reason for it.
Yeah, there's definitely no correlation to better health outcomes, that's for sure, which ultimately, I always kind of come back to this. I'm like, whether it's employer sponsored healthcare, Medicare, Medicaid, individual health insurance, direct to consumer healthcare, like the end goal is always, we call it the member in our world, but the patient in your world, right? Like, are we serving them? And when we when we look at the way that pretty much everything works, it's like, are we really serving them? No, we're not. So if we, I kind of feel like, and I know that this is an incredible oversimplification, but who are we really serving, right? And like, let's design something that serves the end user that we're all apparently working for. And then let's remove all the misaligned incentives in the process. And then generally you're on the path to a much better experience financially and in terms of health outcomes. When you talk a lot about like transitioning from sick care to a more proactive care, do you believe that primary care, like a quality primary care experience, is at the crux of that, or is there more to that concept?
No, and I think both are important. I mean, if you're, thank God, if you're ill with something, we have the ability to, to fix that. It's quite miraculous, some of the achievements and the outcomes. So, being able to go into your brain or your heart and pull out a clot, and it's remarkable. Or some of the diagnostics that are developing, so we could tell ahead of time you've got something, and here's what you have to do to prevent something bad from happening. um, for my part, it's just, and I think many other people, and there's this whole movement now, integrative medicine is one stream of it, lifestyle medicine is another stream, but they're all very similar, whole person health. It's this notion of, maybe we spend a little bit more money and effort and resource um, up front, so that I don't need to have that life-saving procedure 10 years from now, right? Or 5 years from now, or 15 years from now. I'm glad it's there. I don't want to, stop that sick care, if you will, illness care, chronic disease management care. But I personally, I think most people would say, if you could help me prevent that, I would much prefer that. And by the way, it's obviously overall lower cost, much more efficient to do that. And I think that's the movement that has, arisen over the last few years and decades. This notion of recognizing that, food is medicine, and which is, again, we talk about that. What's really important is food as medicine also goes back to what I mentioned before about financial health. You can't eat healthy if you don't have the money,
Right.
right? And if your money is being stolen, if you've got this huge healthcare tax that's taking it out to pay for this sick care, medical industrial complex, and so that's where, again, it goes round and round. But I will say, and I hope, I know we're talking a lot about the issues and the problems and the challenges, which again, I think is important to identify it, understand it. To your point, and I completely agree with you. I don't think most people have any understanding of how the system works, and we're talking about half the healthcare system, over half. I don't think they have an iota of understanding of the complexity of what's happening. I had a friend who said to me, Zev, you really won't understand healthcare. Actually, this was when I wrote my first book, Reframing Healthcare. He read it before it was published, and I used him as a sort of editor. And he said, Zev, you really have to follow the money. If the only way you'll understand healthcare, and I tell you, I will never ever forget that. He said it to me once. He said it to me many times, And I began after that to start to do exactly that. Let's talk about the money. Let's see where the money flows. And you want to talk about the problem. That's where the problem is. My second book, I basically said, look, we think the transformation of healthcare is going to happen with all this artificial intelligence and this scientific innovation. No question that's going to move things forward. No question about it. That being said, if we don't change the fundamental financials, the fundamental business model, the payment, the reimbursement, if we don't change that, all that the technology is going to do is make the system worse. It'll
Exactly.
just,
And more
right?
expensive.
More expensive. That's
That's it.
exactly right.
I could not agree more with that statement. So something that Donovan actually says often, and I'd love to hear your perspective on this. I think sometimes for employers, there's confusion between like a medical condition and then what a claim is, right? Because you'll speak to employers all the time, obviously, and they'll say things like, "Oh, well, we got a 15%, and our broker said it's because we had bad claims." And I'm like, okay, interesting. Or we had a few cancers on the plan and a kidney dialysis and a NICU baby or whatever, right? Like we had these catastrophic events, and they're thinking like car insurance, like, you're using it a lot, so you should obviously pay more. And we always tried to differentiate between you don't expect your employees to not have conditions. We can't control. I mean, obviously, to a certain extent, we want to be proactive. Food is medicine. Hopefully, people don't get sick, but ultimately they will. And the goal isn't to not hire sick employees or not have sick employees. The goal is, what's this claim amount, right? A claim is a dollar amount for a covered condition on a health plan. A medical condition is a medical condition. We're not controlling the medical condition, but we would like to control what we're paying for that medical condition, which is the claim, right? Because I'm sure you know this better than I. Five of us could walk into the same hospital with the exact same issue, but with different insurance cards. And there will be a massive differential in what you pay versus what I pay versus the other three people. And I think that, and not to say like we need a one price system or anything like that, because I come from a country of nationalized healthcare, and I have seen the pros and cons to that as well. But I don't think that a lot of people really understand, like, they're being told you have sick people and you have chronic conditions and you have all these things. And it's like, well, that's not where the focus needs to be. The focus is like, what are we paying for those? Just like your point with the AI and all of that, like, that's great, but everything has a cost. To like, why aren't we call it managing the frequency and severity of claims, right? So I don't know. There's just,
well, I love it. So first of all, I mean, you're teaching me. I love that distinction between a medical, the medical condition and or conditions and the claim, because we in my mind, you're absolutely, I think all of us kind of meld them together, and they're not. And I love the idea of, listen, people are going to get sick, they're going to be sick, and just let's, we accept that, and that's not the problem. The problem is how that's translated into a claim.
yes.
And if we could focus on the claim,
Yes.
not, and figure out how to optimize that. Now, you got me thinking, because what's really interesting, again, talk about perverse, or, the system will try to, we use the word optimize the claim. So you've got industries within industries. I mean, consultants and, teaching the industry how to make the claim as large, the monetary claim as large as possible for any given medical condition or conditions.
Yes.
I mean, people make a lot of money, obviously. Oh my God. Oh, coding specialists and revenue specialists. And I mean, I can't tell you how many year after year of training programs to, they would use the word, and I consider it I mean, to be fair, doctors undercode, because that's not our business. I mean, again, why should, this gets me so upset and angry. Why does a doctor have to become a coding expert? Why do I have to learn? I mean, it really pisses me off where you have, again, these people are so brilliant, they're so smart, they're so well trained, They want to take care of patients. They want to make people healthy. And then you impose upon them that they have to become a coding expert. You have to learn what the codes are for hypertension and diabetes. And by the way, if they have diabetes and they have some eye disease on top of that, or if their creatinine, their kidney is injured because of their diabetes, that changes the code from a 5.1 to a 5.10123. And did you know there was variation on that? And I really, I'll look back on my life, and, as I get older, I get a little bit more honest, I think. And I think what I'll look back, or just even as a writer, an observer of the history of what we've been through in healthcare medicine, the idea that a physician had to become, or any clinician had to become a coder and biller, and that was imposed upon them, and they were, and your salary is dependent upon it. So it's not just like a nice thing.
Yeah.
You get dinged for it severely. I mean, I've seen doctors get hauled in front of people and admonished and yelled at for not. I mean, this is not uncommon.
Mhm.
Why does that have to be? Why does a person who's been through college and medical school and residency and fellowships, why does that person have to learn how to be a data entry clerk? Because that's exactly what you've made them into, where they have to record everything in this thing called an electronic medical record, which is many people would call it a fancy billing system. And and then you tell them, by the way, you're spending maybe 50%, maybe 60% of your work time actually coding and transcribing and doing data entry and data retrieval. It's so, if you I did this years ago. It actually got me a promotion, where the doctors, I entered into a wonderful multi-specialty practice, large in Massachusetts. And the doctors, the administrators, would say to me, "Oh, the doctors are belly aching." And I said to the administrators, "What do you mean they're belly aching?" They're saying, "Oh my God, they're complaining about the electronic medical record. Just they should shut up and just do their work and learn how to use the electronic medical record system." They were switching to a very well-known system, and I said, "Well, they may be belly aching, but how do you know that? Maybe they're actually telling you the truth. Maybe they're telling you something you should be listening to." And they just kind of, waved their hands at me and walked away. And so I began a study, and I'd been trained in Toyota Production System, lean process improvement. And I took a stopwatch and a pad and a couple of people with me, and we sat in the corners and basically tracked doctors. I did this in 2005. It was done afterwards by other people, and they've published it. I actually should have published it, but whatever. What we discovered with these time motion studies was the doctors were literally spending less than half their time actually seeing patients, like in direct patient to patient care, where that's where the value proposition is. And then I calculated that amount of time that they weren't doing it, how much we were paying for them. And I showed it to the CEO. It was literally $1 with 7 numbers after it and 7 digits after it. And I said, this is how much we're losing every year, because the doctors are not actually doing doctoring, or the APPs are not doing doctoring. They're doing walking around, looking for things, doing data entry, data retrieval in the electronic medical record, figuring out coding, all these things. And you're paying them a lot of money, and here's how much it's costing you. And so I literally showed that. And again, I should have published it because others published it years later. And then so basically the CEO said to me, "Well, okay, I want you to stop doing what you're doing, and I want you to fix this."
Fix that. Well, and you think about, I mean, a salary for someone doing data entry is probably going to be 50 to 70 tops, right? Versus what you're paying a doctor to do, a lower.
Right, probably 50,000, right, $50,000 a year, as
Yeah.
opposed to 5 to 10. I mean, specialists can earn a lot more than that. So yeah, no, it's really, and also, it translates into access, right? And then we did that. We said, listen, if in this time that they were wasting doing coding and billing and data entry and data retrieval, if they were able to see even a fraction of that time using patients, we'd have so much more access. It's not just the money and revenue reimbursement, it's also the access to care, and you could probably translate that into life saved. And so it's a big deal. And it's, again, it's just another example of a system, to what you said before, perverse in that, it's not centered on the patient. It's not centered on the employee. This is largely about the industry, and it's somewhat self-serving. And again, I don't, like many others, this is not about socialized medicine. This is this is not about reducing competition. None of that. I think it's about changing the game, changing what you're competing for, and making it, actually, quite honestly, making it a true free market, as
Yes.
opposed to some of the constraints now.
Yeah, I would agree with that completely. I think for employers listening, the key to everything that we're talking about is just to look at, I'm going to use your term. And actually, I think it's funny because I write this in all the books that I sign for our documentary. Follow the money is literally my favorite saying. I put it on every book that I sign. But in your health plan, like for employers, follow the money. How is all the different pieces of the supply chain, how are they getting paid? Are they getting paid more when you're paying more, or can you create something that's more aligned with your success? Like that is ultimately the way to, quote unquote, like design a new system on the employer side at the very least. I want to give you an opportunity to say like one last thing to employers before we go into caregiving. But if you could give them any piece of advice, whether it was designing direct primary care, or focusing on the primary care aspect of your health plan, or anything. I know you were just the CEO, you were making these decisions for a relatively big company. What advice would you give employers that are kind of like, oh, this is a lot?
It's such a great question. It's such a
Like
great
one
question.
first
It's
step.
such a great question that I don't have a good answer to it. It's making me think. I think one thing I would say is to, I don't know where this fits. I suspect, again, this fits very, very low on most CEOs' plates. I mean, they've got a lot of other things to do and worry about and think about. Healthcare, the healthcare plan, I think for their employees is probably, even though it may be the second or third biggest, after salaries and wages, item in their budget, in their P&L, but I don't know that they give it enough thoughtfulness, or they dive into it enough. And they sort of relegate it to the HR and the HR benefits management department and all that sort of stuff. I mean, if you think about it, this is what I would say to employers. If you think about it, after your salary, okay, and perhaps after, how you get treated at work, those are two, I think, really important things, right? After those two, I think your health care, your health insurance, your health benefits through your employees is probably the third most important thing you're thinking about in your company. And if that's the case, then my question to CEOs and C-suite folks is, how much time are you spending thinking about your employees' healthcare benefits, their healthcare plan, their healthcare experience? If it's the third most important thing to them about being there, then where in your prioritization, where in your week, where in your day are you actually spending time and effort? How much do you actually know? And I'm looking, and I'm going to say I'm as guilty as anyone else about this. I did not spend enough time. I have not spent enough time. I don't know enough about it. And it is one of the reasons, to be just quite frank, I've been in my own podcast and my own readings, I've been exploring this even further. I'll be honest, I'm going to the Health Rosetta conference, the Rosetta Fest, and in the end of August, where it's 3 days of nothing but employer-based healthcare with the most brilliant experts in the country, both from the broker side and health plan side and clinical leadership. And so I reached out to you and Donovan and interviewed you guys, and I've been reading your stuff. In fact, to be quite honest about it, I just read your brief about self-funded versus level-funded plans. And I will say, as much as I thought I knew about it, I learned something through reading your brief. And so for me, I'm in whatever role I'm going to play in the future, I'm going to make it my business to spend a lot more time really understanding my own employees' health plan, their benefits, and their experience. I mean, like we were talking about before, if they want to see a primary care doctor, how does that happen? If they want to see a specialist, how does that happen? If they want to see a healthcare coach, how does that happen? So I would say that I could, a blank statement that I would say that C-suite and CEOs don't spend enough time, and they should spend more time on their health plan.
It's super interesting. I look at the top performing organizations in our book of business, right? So we'll design multi-year strategies, usually like a 3 to 5 year plan to get them to like real transparency. And then the ultimate goal is employee programs like free cancer treatment, free imaging, direct contracting with centers of excellence and all sorts of things, and free specialty drugs and free babies and all the things, right? Like it's to get to that end user having an exceptional experience point. The catalyst, what determines how quickly they get there, is how engaged the CEO is every single time. Like the fact that you said that, because I asked this question to most of my guests, like, what's the first piece of action that like you would recommend? And it's usually just like, find a broker that aligns with you, which is great advice too. But you're right. We got to go one step back, which is when we have an engaged CEO, we literally, instead of a 5-year transformation, it's 18 months, 2 years. I had a conversation yesterday. This incredible company, it's a global company, and the CEO is fixated on his American benefits. They've got about 2,500 employees in the US, because if he looks at his global benefits budget, 65 to 70% of it is American benefits, healthcare, but it's not even close to half the population of the company. So the spend is completely disproportionate. So he started to like research. He saw our documentary. He saw other CEOs of our clients talking about their success. And he's all in on transforming this, right? So we're meeting with his benefits team, and they're like, our CEO is crazy. Like, he thinks he can fix American healthcare, and he's nuts, right? And we're like, no, it really does start with him. Like,
he's not nuts. And in fact, there are other CEOs that have done exactly that.
Yeah.
I mean, classic example, Mr. Rosen.
Yes.
Was it Harry Rosen? And unfortunately, he passed away recently. He had he was a hotelier and in Orlando, has this hotel chain, and built it up from nothing, and just did exactly that. He was a CEO, said this, and I had the privilege of interviewing him a number of times and speaking with him and his team. And he did exactly that. He said, this healthcare system is absolutely stupid. He was saying to me, he was very, very blunt. And he had spent time in the Army. He said, I learned one thing in the Army, and it was KISS, keep it simple, stupid. And he said, all this stuff is ridiculous. He said, here's, he looked at it, he did exactly what we talked about before. He said, what's the problem? How do I create it, just to take out all the garbage and to make a simple solution? Offer these, and again, these are the lowest paid people. These are people cleaning hotel rooms and the grounds and stuff like that. A lot of them, immigrants, and and he gave them the best healthcare system bar none. And in doing that, I mean, he would have doulas going into the hospital with these immigrants who were giving women who were giving birth. He had an on-site clinic that he created, Rosen Care. He would have case managers going to their homes. And in doing that and spending the money, again, remember we talked about before, great example, spend the money up front. He saved tremendous amounts, hundreds of millions of dollars over the years. That money he poured back into his employees. And so he was giving, they got more health care, they got other benefits. I mean, he was paying for their kids' college educations. I mean, that's what he did. And then he took that and he adapted it to a community called Tangelo Park down there. So he took it out of the company and he showed you could actually do this in a town, a poor town. So anyway, I think what you're saying is brilliant. It's, maybe you and I, Donovan, should do something about this. Maybe this
We
should be an
should.
actual. You want to do that? Let's do
Yeah.
because I think this is an initiative. We can call it
All the CEOs, like a call to action, like a really focused, targeted, look what you can do. I love it.
I'd love it because I mean it's, we have clear, there are in the literature on change and change management, there's this thing called I think Keystone. So there, I used to study habit formation and stuff like that, and there are these keystone habits. There are these things. So if you change one thing, it has an outsized impact on everything else. It has these ripple effects. And so, and I learned this from real experts at like Stanford who studied, behavior change and habit formation and whatnot, and Duke University. And, I think this is one of those examples. There's a lot of things you can do. It's a very complex, remember like we were talking about, but having the CEO inciting, nudging, guilting, navigating,
Championing.
championing the
Talking to the
CEO to
Yes.
actually say, this is not about your HR director, your CHRO. This is not about your CFO. This is not about your chief marketing. This is not about your customer experience officer. This is about you. And we've got a boot camp. This is a keystone effort. This will change everything. We've seen it. We have examples, and we're going to walk you through how to become, I can't believe we're actually doing this online. We're actually showing the world how to create a new company.
Well, and so the groups that we've done this with, when the CEO from the get-go, and there's certain CEOs that are like, all right, I need proof of concept, and then they give us a year or two and they see it, and then all of a sudden they're like the ultimate champions, and that's great. But where the real quick and culture level change, not just financial level, but like culture and health outcome change happens, is when that engagement is ignited, catalyzed by them, right? And yeah, I'm sure we could together find the greatest example. Yeah, we're doing this.
And this is the thing about change too. You go out to 100 CEOs, 10% will tell you you're an idiot. 80% are going to be like you said, I got to see proof, come back to me in a year or two, show me what you could do, and then maybe I'll get involved. And 10, out of 100 will say, I'm in.
Yeah.
And, and that'll be the 10 where, once they do it, you go back and it'll be like, hey, they did it.
What's been really interesting is so we were at a conference with one of these CEOs that totally championed his healthcare transition and transformation. Since that, he has been awarded one of the top workplaces in America, top cultures in America, top leadership team in America, like huge awards. Not surprising. He had an employee leave recently, and they said the thing they're going to miss most is how much they care about their health. And the outcomes of their health, which I thought was amazing. But what was really cool is he was speaking on stage, and there was another company that's actually a competitor to them in the audience. This was in Orlando, and they came up to us after and said, "We want to do the CEO. We want to do exactly what he did, and we want to do it as quickly." And I'm like, "Okay, all right, let's do it." Right. So like we meet with them in 2 weeks to show them their pathway.
Oh, so you've already started.
But it's that story, right? Versus like me going out there and being like, hey guys, you can do it. It's like, no, you're talking to somebody that, is at your level and whatever. So it's just so powerful to share those stories. So we'll definitely find an outlet for it.
That would be cool. Let's see if we can follow up on that.
Okay. All right. I want to wrap up with some of the caregiving. So you've had a really unique situation personally arise over the last little bit. I want to give you an opportunity to share whatever you want to share about that. And then just have a little bit of a conversation around, as employers or employees, it's difficult to be a caregiver, and it's something that, you don't really think about until you have to. And then at that point, you're kind of looking around and you're like, well, what support do I have? So I'd love for you to share your story and us just kind of talk through a little bit of that.
Yeah, and I almost feel first of all, thank you for asking the question and giving me the space to speak about it. Chelsea, I feel like this is almost a whole different episode, but
Yeah, you want to save it for another day?
yeah, but let me say one thing about it in the context of what we were just talking about, because you asked this question, like, what does a C-suite or CEO may not realize about, about their own employees' health and healthcare and benefits. I think one of the things that I had not realized, even though I interviewed experts on caregiving and individuals who had been, caregivers to their children or to their parents on my podcast, is when someone gets sick, when your employee gets sick, or if you have an employee and their spouse gets sick or a family member gets sick, it's going to have an impact. So when my wife became ill over the past few months, and even more so over the past few weeks, I was working, full time, and it realized that I had to cut back severely, to take care of her. And again, we have means, and so I was able to hire some folks to to help and all that. But even with that, it was, I mean, I really went from being a CEO to a caregiver like in 7 seconds. And it it changed my life, changed me. I am thinking about writing a book about this experience because it is so isolating and isolated, and the things I've experienced over the past few weeks are like nothing I've ever experienced before in my entire life. And while I've heard about caregivers and I've heard from caregivers and I've written about it even to a certain extent, I just never understood the impact it has on on the family and on the caregiver. And again, as an employer, it's not just your employee. If it's their family, and if someone in their family, whether they're employed by you or employed by someone else, you're going to be affected by that. And so a lot more to say. I would love to dive in another time with you
Yeah.
and
We'll
really
dedicate
share
an
with you.
entire episode to, and I feel like as you go through this experience, as difficult as it is, you're just so brilliant. You'll have a lot of really interesting insights that we can dive into. And then I'd also like to get deeper into like how employers can structure benefit packages specifically for these moments of need for their employees. So awesome. Well, I just love talking to you. I feel like I could talk to you for hours and hours and hours. So it's always fun because it's very intellectual, obviously like intellectually stimulating, but it's also what I really, really enjoy about you is you always get tactical too. So, like there's real things that CEOs can do and direct primary care. There's things we can do right now to affect change, right? It's not just academic. So thank you for being who you are. Thank you for being on my show. Where can our listeners find you if they want to connect?
ZeevNeuwirthHealth.com. If they Google me, they'll get to my website, and got a podcast, the 2 books I was talking about, and yeah, I'm delighted to talk to anybody.
The name of your podcast again?
It's called Creating a New Healthcare, which I started at 8 years ago. We're going into our 9th year, actually, in August this month, or next month rather. And what's really interesting is that title, Creating a New Healthcare, has become, I think, much, much more critical now than it was 8 years ago, which is kind of interesting because I always thought about changing the name, and I was like, no, that is what we need. We need to create a new healthcare.
Yeah. And when I was on your show, I was like, oh, this is so timely. I had no idea it was an 8-year-old title. So no, you're absolutely right. Well, thank you again for being with us. Again, we'll have Zeev back, guys. So don't worry. We have much more to talk about, but please connect with him, read his books, definitely follow him on LinkedIn. Huge thought leader on the healthcare delivery side. And I have a feeling you're going to be making quite the impact on the healthcare financing side too. So thanks for all you do.
And I look forward to working with you and Donovan.
Thanks, Seb.